Good afternoon. So welcome to the webinar titled Intensive Care Management Services for Patients with Multiple Chronic Conditions. This webinar is part of the Clinical Performance Improvement Network, or CPIN's webinar series. CPIN is a collaborative production of the Washington State Medical Association Foundation for Healthcare Improvement, the Puget Sound Health Alliance, and the Washington Academy of Family Physicians. This webinar is being specially recorded following some technical difficulties we experienced during the actual scheduled event. My name is Colette Rush, and I am a public health nurse consultant at the Washington State Department of Health in the Practice Improvement section. I specifically work in the Heart, Stroke, and Diabetes program, and I specialize in the management of hypertension and in practice improvement with a focus on chronic disease management and the patient-centered medical home. I bring a variety of healthcare experiences to the table, and I'm really excited to be here to share the information I have with you as we all learn how to better care for these patients with multiple chronic diseases. So I thank you for the opportunity to talk about providing care management services in primary care settings, and also about the new work about to be launched to the Department of Health's Practice Improvement section that could assist you in this work as you go down this road, if you choose to. I want to say up front that although we have lots of relevant and practical experience here at the Department of Health in practice improvement, to bring to the subject, we're certainly not experts on the subject as of yet. Like many of you, we are on the hunt for best practices and are also scouring the literature to learn what works the best. What we plan to do is use our 13 years of experience from providing the IHI-type collaboratives, and we'll use these quality improvement principles in working with primary care within the patient-centered medical home model to hopefully learn more about what works. Hopefully what I present today can provide you some additional information to consider as you decide whether to create a care management program and how you might go about doing so. So the agenda is that we're going to talk today about is patient complexity in primary care, the impact of chronic conditions, defining care management and its value, 5 key components for creating a care management program, and then the Washington Healthcare Improvement Network, or WIN, which is the work we're going to be doing here at the Department of Health, that will be providing regional and a statewide support for practices. I want to frame the discussion today by starting to talk about some definitions. These two terms, care management and care coordination, can be very confusing, as various agencies and organizations locally and nationally use the names a bit differently. So there does seem to be agreement in describing care coordination as a set of services to support a patient with their referrals, or coordination when they are hospitalized or use emergency department. Now, a large percent of your patients at one time or other would be referred to a specialist or be admitted to the hospital or ED, and could need help in navigating the system, and that's where care coordination comes in. And if you look at the top, the definitions at the top box in blue, these are the safety net medical home initiatives definitions that we use here. And so care coordination is thought of as referral or transition management. It's a name used to describe the essentially non-clinical but important functions of providing information and logistical help to referred patients, and so on. However, in each of your practices, there is a subset of these patients who need more intense clinical management. And there is a continuum of this clinical services that could be provided, matched to the patient's needs. Perhaps the patient's blood sugars or blood pressures are not to goal and they require some health coaching or more intensive medication management using treat-to-target principles, progressing all the way to patients with complex conditions requiring a multidisciplinary team to support them. These patients are in the small circle above in the diagram. So I'll be focusing primarily on the services provided to those most complex patients in describing care management services. But I will touch on the other levels as well. We will talk more about how to stratify your population and to decide what services you will provide and for what patients a little later. These services require some significant changes in what you're doing in your practices, and the type of changes required are well described in the patient-centered medical home model of care. So let's talk a little bit about what the primary care patient looks like these days, and something that you are all aware of, but for us to kind of introduce the subject, I'll kind of go through them. The patients you see in primary care are becoming more complex. They have multiple chronic conditions and are frequently elderly, are frail elderly at that. The numbers are rising because of our aging population then. And these patients account for the biggest percent of healthcare costs. Many have 4 or more chronic conditions. The data says, especially if they have CHF, diabetes, or depression. They frequently have depression and or anxiety, which complicates their physical health and can have significant social services needs as well, as we all know. These chronic conditions can decrease the patient's quality of life and limit their normal activities. AHRQ reports that, AHRQ reports that about 20% of these patients can have at least one or more limitation in their normal activity, activities of living. This competes with their patients' their ability to manage their condition, of course. Care management is considered an approach that can improve the quality of life for patients, improve clinical outcomes, and decrease costs or healthcare utilization. In essence, and to make it even more simplified, it serves to decrease the workload for the patient and for the clinician, and increase their capacity to manage the patient's health or the health of the patient. Providing care becomes more difficult and more costly as the number of conditions goes up, as shown in this graph, and that's not surprising, but the data does back it up. Both the patient, clinician, and practice team need to juggle lots of things in order to manage the health of the patients with multiple conditions. In 2005, ICIC, Improving Chronic Illness Care Organization, reported that 63% of patients with Medicare had 2 or more chronic conditions. A year later, AHRQ reported that for those over 65, 73% had 2 or more conditions. This is complicated by the fact that many of these comorbidities are mental health conditions, which are not well identified or managed in primary care frequently. This is even more true for the patients with dual eligibility for both Medicare and Medicaid benefits. For cost figures, the latest figure I could find on costs are that 98% of Medicare costs are for individuals with chronic illnesses, 98%, and over 66% of these patients have 5 or more chronic illnesses, making it very complex to manage these patients. And so these folks certainly require some special focus from us. And talking about mental health conditions that we see in primary care, Dr. Caton from the UW, University of Washington here in Washington, at the Ames Center reports from their research in behavioral health in primary care that 40% of patients with multiple conditions also have depression, and 15% have anxiety disorders. And that mental illnesses are 2 to 3 times more common with certain medical illnesses, such as diabetes, arthritis, chronic pain, and heart disease, which of course we see a lot of in primary care. Behavioral health conditions can just play havoc on a patient's ability to care for themselves, and they can actually cause physical health complications. So there's bidirectional influence here. It's reported that people with mental health conditions in the U.S. remain significantly undertreated or poorly treated. And this is complicated by the fact that primary care clinicians report they really can't find the support they need for their patients in the community very well. Depression and anxiety disorders are common in primary care. 20 to 25% of patients in mixed income populations and up to 50% of patients in clinics serving low-income populations have depression and or anxiety disorders. Per the National Comorbidity Survey, 59% of those with mental health conditions in the population have not been diagnosed even. And of those diagnosed, 56%, so over 50%, are seen by primary care. And this seems to be increasing. So treating the patient's mental health condition, or the most common, depression and anxiety, where they usually receive their care in primary care, does make sense. Primary care practices are treating the whole person. And because of the interrelationship between medical and mental health and improving health, it makes sense to treat those together. Many times you can't successfully treat one without treating the other, especially among certain disease groups, such as diabetes, cardiovascular disease, and depression, which again, like I said before, have this bidirectional influence. There's a strong hypothesis by folks at the AIM Center who've done a lot of research, and this is their specialty area, that expanding access to mental health treatment in primary care would lead to reductions in use of services and costs for the physical health problems. Per ARC, again, a publication prepared by Mathematica Policy Research in 2010, they say that more than 40 trials in diverse primary care settings have demonstrated that PCPs, primary care providers, can deliver effective treatment for depressive disorders and improve patient outcomes with the help of a mental health specialist in a consultative fashion. In a study including about 9,500 adults from all over the U.S., all age groups preferred receiving their care from a primary care practice rather than from an outpatient mental health center. And for those over 65, the differences were huge. 8% preferred outpatient, 49% in primary care. So this is where we reach our elderly population. So there is a lot to consider in a 15-minute visit. It's not really possible for a clinician to get it all done, I will hypothesize, at least not alone. And indeed, Dr. Margolius and Dr. Bodenheimer, who've done a lot of work in this area, show that their research shows that only 50% of patients understand physicians' instructions after leaving an office. Only 50%. And 70% of patients do not take medications as prescribed. If there was even a program set up at a clinic just to address these two things, it could make a tremendous impact. We've talked about the non-compliant or non-adherent patient, but there are a lot of reasons a patient doesn't take their meds buried in these percentages that a care management team or health coach could help with. And as a side, I just want to point out here at this point that there's a national program recently launched, if you haven't heard about it yet, Script Your Future. It's on scriptyourfuture.org, that provides many tools for you and the patient to help them better take their meds as prescribed. So there's a national movement around this issue as well. And then even when patients are taking meds as prescribed, but their conditions are still not controlled, treatment intensification occurs only 30 to 47% of the time. But again, there are a lot of reasons for this buried in those percentages. And finally, Dr. Bodenheimer found, and Margolius found that even though shared or collaborative decision-making between the clinician and the patient has been shown to be critical in assisting a patient managing their condition, it happens only about 9% of the time. 9% of the time. And this is just not a problem of knowing what to do. It's not a problem of knowing what to do. You know, this is a time issue, especially with individuals who have multiple chronic conditions. And again, there's a low comfort level and not the time to address mental health conditions. 66% of PCPs report that there is poor access to mental health care for their patients. And, excuse me. And health screenings are recommended, such as depression screenings and others, but who should do these in business practices, in a busy practice? And what do you do if the screen is positive? And this is, of course, complicated by patients having many psychosocial barriers to health. So complex situation we have. I love this cartoon that I found on the web, but it's a little grim. You know, and if you read this, be sure to take this drug exactly as directed, and all sorts of directions for doing that right. The patient may understand about as much as this person in the cartoon, especially when there are health literacy issues. So it really shows the issue well, I think, a part of the issue. Okay, excuse me. And it is a struggle for patients to do all they have to do. You know, it's just getting in the way of them living their lives. This is a slide from the Minimally Disruptive Medicine website. And I'll talk a little bit more about that in a minute. But it describes the work of being a patient with multiple chronic conditions. This describes the time taken for just managing, a patient just managing their diabetes. And in a study, a patient self-reported about 48 minutes a day, and this didn't include administrative time, driving to the doctor, calling the insurance company, buying meds, that sort of thing. And they say that's just not enough time to get it done, even to get the diabetes care done. The ADA describes that states that it takes about 122 minutes per day, plus the administrative tasks, so 143 minutes a day, to get the work done, a patient's work done for managing their diabetes. And this is just for one condition. If you add up other medical and behavioral health conditions and psychosocial barriers, it is impossible for the patient to really manage their workload. So again, those original percentages I showed, there's lots of reasons why folks don't do what we would like them to do, and they have to prioritize. Everybody has to prioritize what they're able to get done. These bullets describe an idea and an approach that folks at the Mayo Clinic, Dr. Victor Montori and his team, are calling minimally disruptive medicine, from the slide from before. He recently spoke at IHI's annual conference and was rated in the top 10 best received of all the speakers. I wish we had more time to discuss this in detail today, but they do have a website, and there are various videos online of Dr. Montori talking about this. It's really fascinating. They also have created, tested, and now offer to the public some shared decision-making tools that have been well received by clinicians that you might want to check out. But basically what they are describing is through a shared decision-making process between the clinician and or team, the patient can fully understand risks and benefits and then be fully transparent to the practice about what they can and will do, you know, given the context of their life and their values and goals and what they're able to do. Because of this transparency, then, the clinician can help the patient prioritize what is most important. This all serves to reduce the workload of the patient. Otherwise, they have been prescribed another medication and said they would take it but really don't plan to take it because maybe they can't afford it. And if that's the case, they may make decisions that could hurt them. So maybe their priorities, if they have to prioritize on their own, which is a type of workload, they may prioritize in not the best way. So if there's full transparency, the practice team can support the patient better through a shared decision-making process. The patient will make decisions based on their own understanding and their values and because of what is going on in their lives. So how can the clinician and team optimize the choices the patient makes? This is the goal here. This builds capacity to manage their conditions. So care management is a delivery innovation that could help with this, and also could help with the clinician side of a complex practice. But it will require redesigning how care is delivered. And the patient-centered medical home model can be a guide. So all of the previous slides were making a case of why something different is needed, and care management services could help on both sides, decreasing workload and building capacity for both the clinician and the patient. So the patient-centered medical home model can be a guide for this. And ARC quote, an ARHQ quote, patients who have complex health needs require both medical and social services and support from a wide variety of providers and caregivers. So the patient-centered medical home offers a promising model for providing comprehensive and coordinated care. The 8 components of the PCMH are in this, and you can read them there, and you are probably already familiar with them. I realized that it said 8 components. I only put 7. I left out empanelment in this list, I see. So just know that that's one other. The key components for a care management program line up well with these. Okay, onward ho. So key components to consider when building a care management program. As I looked through the literature and studied and researched this subject, it seems, and talked to a lot of different people, it seems like 5 areas really popped out. Interventions from the programs that have had the most success seem to fit into these 5 categories. And out of the 15 CMS Medicare demonstration projects in 2002 to 2008, in looking at successful care coordination or care management models used in Medicaid programs, the key interventions generally shared by all these included these 5 major areas. Each of these areas could be a separate discussion, but I will touch on some of the key points of these. Developing and restructuring the team. So I hope I've made a case for a team-based approach to care. That's the main point of those previous slides. A team-based approach that includes care management. And this really can't be done in the current primary care design. There's been a lot written about the team-based care, and what makes for a highly functioning team in primary care, especially in the context of PCMH, of a patient-centered medical home model. The Community Preventive Services Task Force reported back in May that in looking at just blood pressure alone, in a review of 77 studies, the control of blood pressure improved the most when care was provided by a team. For a patient with multiple conditions, it's critical that a team be multidisciplinary, and this could include a nurse care manager, a behavioral health specialist in the clinic or outside, working in partnership or in consultation with the clinic, An MSW if the patient has many social support needs, or connecting with social service agencies in the community. Could be a community-based pharmacist for medication management, and so on. But team-based care doesn't just mean identifying positions and roles. It requires a complete change in how a team communicates with each other as a team and in the communication with the patient. And also includes everyone having a voice, including and particularly the patient or caregiver, which is critical in the shared decision-making process. Excuse me. It means looking at workflow and perhaps needing to do some pretty significant redesign to train and use staff at their highest capacity and to the best of their abilities and for the highest and best efficiencies. And training and developing mastery in the tools and approaches for the team. So a lot of training. Several programs that I researched, motivational interviewing was one of the first things that they trained everyone on. So programs start with providing comprehensive training for self-management support and for motivational interviewing for all staff. So everyone is approaching and working with the patient in the same way. That's many people's first step. And there are the tools for providing care management services that staff would need training for, such as building shared care plans between the clinician and the team and the patient and other specialists, intensive medication management with treating to target and stepped care approaches, health coaching, what that is and how to do it, patient activation through self-management, goal setting, and motivational interviewing, and also training on the use of screening and monitoring tools. So there's various things to get started by training your staff to do these things. So this is a very busy slide, but it helps illustrate what I was describing in the last slide about the functions or types of services and staff and roles. Down the left side, I've listed various functions or services that could be provided by a care manager or a care management team, depending on what your population of patients' needs are, and the kind of program you decide to build. This is just a list of possibilities. Not that you have to have all of these, or not at first, but it gives you an idea. And there are probably other things that I've missed that could be in that grouping. Down the right side is all the possible staff positions that could do some of this work. Again, I probably left some out. The idea is to match the function with who might be able to provide that for your practice. So folks that might be able to do that service, that function, maybe in your practice or outside your practice, or you maybe need to hire someone, etc., or consult with somebody. Multiple functions can be done by the same person, but a nurse care manager would not necessarily do it all. It would also be driven by the patient, depending on what they needed. If they had more social barriers, and MSW would probably be the primary person they work with. The coordination of referrals, for example, for that patient could be done by the person that is handling referrals for the greater population, the care coordination person, if you have that person. Some of the services may be partnerships you develop outside your clinic and will need to be linking with agencies outside the clinic, like social service agencies, like the AAAs, for example. Providing intensive medication management could be done by community-based pharmacists. Care management could be provided by specialized home health care managers who are getting trained. There are home health agencies are getting trained around the state on providing care management services. A patient may need medical management services, mental health services, and social services supports in varying degrees. and they may need one or more of the services. Mental health consultation may need to be provided by phone or telemedicine, especially in rural areas. For example, the UW, University of Washington Ames Center does this. They provide this service for rural community health centers. Also linking with care managers in the community. If you will be a provider for the managed Medicaid clients in this state, which is the most complex, about 5% will have a care manager called care coordinators in your community who are already working with your patients. Knowing who they are and coordinating a care plan with them would be really important and really helpful to you. So then how do you stratify your patient population? And this seems to be the big question. So how to stratify the population and what patients you decide to target in these special programs is really the art in all of this. There's not consensus, not quite clear how to do this the very best. It really depends on what each clinic really wants to do. I want to present some various examples of what folks are doing out there. This step design is an example from Peace Health, who is an integrated system south of us here. They have a very robust care management program. This picture represents dividing the population based on diagnoses and some risk and predictors for utilization that they have come up with, and coming up with a final score that is then matched with services. In this situation, blue is the level that requires less services, progressing to patients in the red category that require most services. A clinic could start with services at the lowest level, developing a program with services at the lowest level, and progressively add services or expertise and staff that can do that. Or they could work on and work up to the highest need over time. Or they could start with the highest need, which would be a smaller group of patients who have the highest predictability of using medical services. So the biggest bang for the buck, so to speak. Care management is an additional expense with additional resources required. So you might not be able to provide this for every patient with chronic conditions. So figuring out how to stratify your population in some way is important. Focusing on those with the highest risk and with the greatest opportunity for a response has been found to be very useful. So is that group of patients that are the highest, the most complex, and maybe even costs have generated the highest cost in services they've received. But providing care management to folks that can't really respond well to the services is also something to consider. Sometimes that top 2 to 5% aren't necessarily the ones that respond the best to care management. I also wanted to point out that care management is a must-pass element for NCQA, Patient-Centered Medical Home Certification. At any level of certification, there's 3 levels, and it's required at any level. Here is the list of the care management functions or activities they list, and they require the care management is a must-pass element, providing the following for at least 70% of your patients. So this also identifies some functions that a clinic might want to put in place. Number 2, main component of a care management program that seemed to percolate to the top in looking at these different programs, it's about the patient. So access is critical. That they are seen if they haven't been seen, so access to medical care, but also being able to get in to see a care manager or clinician frequently enough for good follow-up. And also, it also means being able to reach folks, a patient being able to reach folks or somebody at the clinic when they have any question or concern. This really is important to get those questions answered when the patient has them, if they're having side effects of their medications, if they don't feel good. This alone can really reduce the number of emergency room visits. So that's an access issue. They might say, my blood pressure is very high, what should I do? Or they might say that I think this medication is making me feel really sick. A lot of health coaching can be done by the phone if the patient can actually reach someone. And then for the patient, the coaching is matched to the patient's activation level. That should be a consideration. And collecting and being able to use various tools that can help patients. So as you develop a program, have the tools, screening tools and support tools to help the patient there. A big one is shared decision-making tools available, making those available. So who benefits from intensive care management? Well, all patients can with complex conditions. So individuals with complex conditions and practices, by improving clinical quality measures, quality of life, satisfaction, and increasing practice efficiencies. So all patients and the practices can really benefit from intensive care management. But to also reduce the costs associated with providing care to patients with complex conditions, it's generally thought by many that you have to target the high utilizers of medical services and those that will respond to care management. As I said before, though, I have to say that this is still in some debate what that best balance is of patients. Even though organizations are selecting their patients in various ways and feel that it has been beneficial for them, even though organizations are selecting their patients in various ways and feel that it is beneficial for them, the Intermountain Group Care Management Plus program, who works mostly with elderly, the frail elderly actually, which is probably more of a health coaching model rather than a complex care management model. But I think it's worthy of, it's an excellent program that is worth talking about here. They say that each case manager has about 300 patients. So this is a bit different than working with the most complex. They have had tremendous success, and you can see what they, but they take referrals from anyone that they feel, the patient needs the service. So they're generally a health coaching program. Peace Health uses acuity scores to match patient to the services and the intensity of services that they need. And then the CISLA region. One study in 2009, at the conclusion of the CMS demonstration project, concluded that programs with the best potential for success were those that ID'd patients at high risk for hospitalization in the coming 12 months, not necessarily the highest cost patients. Some groups identify patients who have been hospitalized one or more times in the past year and who have been diagnosed with heart failure, coronary artery disease, or COPD. And a second group identifying those who have been hospitalized at least twice in the previous 24 months and have any of a long list of illnesses. So there are various possible scenarios. And this is something that requires a lot of additional study. And NCQA requires some combination of resource use, utilization, and risk assessment And in the orange there in this chart, they describe identifying complex or high-risk patients should come from a profile of 1, resource use, and 2, risk, which is some combination of the following. And you can read that. So that's the way they look at stratification, which maybe could help you. In those risks, in NCQA's utilization risk profile, they mention socioeconomic risk factors. And this chart came from a talk by Connie Davis, who used to be with the McCall Institute and now works in Canada and does a tremendous amount of research on patient self-management and engagement, and works directly with patients as a nurse practitioner. And she provided this at one of her talks, and the citation is on the slide by Dr. Watson. Excuse me. You can look at socioeconomic factors as a risk for healthcare utilization. So in this example, looking at a population of patients with heart failure and the percentage of patients having healthcare utilization over the previous year. I don't know how they define utilization, but they make this point. If you look just along the left column and disregard the row at the top for the moment, if the patient has no pain, no depression, no social situations, or money issues, there was, in that first box, 26% utilization. Then looking down the column, as more of these issues come into play, there was a greater increase in utilization. Now if you look at levels of confidence or the self-efficacy, if you add that to the equation, the utilization goes up. So if they're confident, it's less utilization. If they're less confident, there's higher utilization. And so if you look at those boxes, you could actually stratify the population based on some of those social economic categories and really focus in on patients and with identify a smaller group that you can really focus in on, which may be down in that far right-hand corner. This is probably not surprising, but it's another way to zero in on the patients you might work with. And since many of these high-risk patients are older adults who frequently do have social service issues or long-term issues, it's important that there is access to a social worker at the clinic, or there's a linkage to the social service agencies in the community, like the area agencies on aging and others. Primary care is still more a medical model, but needs to truly integrate the social services support into the care that is provided, as many of the high-risk patients will need this type of support. One group in South Carolina expanded the grid that I just showed you to apply to their entire population, and indeed do use this as a way to stratify the population and match the clinic resources to low needs or high needs patients. The patient activation measure, also called the PAM, developed by Judith Hibbard and her team out of Oregon, has been well researched and well received and can also be used to narrow down the population. There are a short list of questions that place patients along a continuum of activation around their ability to manage their conditions. I have that list of questions up in the right corner of this slide. You can't see the questions, but it's just a simple questionnaire like that. It has been shown that the farther a patient is to the left of the page, the more at risk for utilization they are. And this, combined with some other stratification tools, can be really useful. And it's also a great tool to use as a care manager to match resources to what the patient needs. The third major component of a care management program is the integration of behavioral health. And I think we've really made a case for that in this talk, or I have in this talk. Patients with behavioral health conditions are already there in primary care, and they need to be screened for, treated, and monitored for improvement using the listed screening tools that you see there, or others. There's the behavioral activation tools that can be used by the care manager to help the patient re-engage when depressed. It would be important that there is a behavioral health specialist to provide consultation, case review, or support to a care manager and clinician, and I'll talk a little bit more about what the AIM Center and the TeamCare program is at the University of Washington. And the use of a multi-condition or a collaborative care approach, especially for certain disease clusters such as diabetes, heart disease, and depression, or chronic pain, depression, and substance abuse. These are two disease clusters that work well together. This, again, was from work at the AIM Center. The AIM Center calls these natural disease clusters that are better managed together, rather than independently because they impact each other. Excuse me. So this is one model for a collaborative care approach that I was just talking about for patients with multiple chronic conditions. It is from the TeamCare group at the UW, part of the AIM Center, and this is from their intervention manual that is available online. They say that treating depression and other mental illness in primary care is great, but it's not only doing that, not only just treating depression. It actually needs to be multi-condition and a collaborative approach, looking at the conditions together, they say. They describe a multidisciplinary team that is built to support the care manager in the support of the patient. And they have a very comprehensive training manual available online, but the core, but this is one example of other collaborative approaches. The core elements of the TeamCare program include there's evidence-based treatment guidelines for each chronic condition, whether it be medical or behavioral. There's a clinical care management information system, so some sort of system to help the care manager track the conditions and track if they're to goal, patients are to goal, and when they've been last seen, and how each of the conditions is affecting each other condition. Weekly case review and supervision by physicians, specialty consultation as needed, and continuity of care with the primary care physician and the nurse care manager. So they talked about a program for a team that's built around the primary person working with the patient, which is the care manager. This is another way to approach it. And collaborative care or integration of behavioral health services can improve the quality of care. Excuse me, as I get myself refocused here. This can improve the quality of care and outcomes of patients with depression, diabetes, asthma, and heart failure. It's a team approach for medical, behavioral, and psychosocial concerns of issues that a patient has. And it tracks and addresses conditions at the same time, so looking at the conditions' relationships to each other, such as depression may need to be controlled to improve medical conditions. So you might have to treat blood pressure, treat depression before the blood pressure comes down, or before the hypertension can be adequately controlled, or solving the cost of the drug issue with the patient prior to working with the patient on blood sugar control. So all of this has to be looked at together, is what they feel. And a fourth area of a key area of building a care management program is meaningful use of information technology. That it's embedded in the system to provide decision support at the population and for the individual. So there has to be information that you receive back about how you are doing with a whole group of patients as well as individually. And a lot of you have registry and electronic health records that do this now. Care management support, the tool is critical, and it can be either very simple or complex, but some way to track patients for the care manager. And then there's key IT supports that I list here. This is a simple care management tool used by the TeamCare folks out of the AIM Center. It's just an Excel file that tracks patient metrics and visit dates, and it has some highlighting for patients that are not to goal and so forth. But the important thing is that it looks at these metrics, these conditions together to see the impact of these conditions and the control of the conditions on each other. More complicated care management tools pull from electronic health record and populate a more sophisticated care management tool in some situations, but both the simple or the complex can work. And an Excel like this, an Excel tool like this can be an easy place to start. But it is critical that in a care management program that there is a tool. And I did want to point out that a core meaningful use standard is that practices maintain continuous relationships with patients through care management processes. And this is by embedding the guidelines into the day-to-day operations and by using registries that proactively identify and engage patients who are lacking important services, which is what I just showed you through one tool, Excel tool. And then the last area that really percolates to the top for what's necessary to develop a care management program is developing partnerships, strong partnerships, and resources in the community. So understanding the community and developing the relationships with the community to support what you're trying to do in the clinic. I've mentioned many of these throughout the presentation, but linking and integrating these services is important for your clinic to be able to address all the medical, behavioral, health, and social services needs for those patients, those complex patients with multiple chronic conditions, so that you can improve their health, their quality of life, and decrease costs by decreasing that health care utilization. Figuring out who all these folks are for your clinic would be another first good step. Whether it be hospitals in the area, specialists that you want to work with, getting some behavioral health consultation, and so on. And I've mentioned this group as well. There are, for the Medicaid, Managed Medicaid program, there will be care coordinators in the community. This is part of the Health Home Network that's just getting started now, Section 2703 of the Affordable Care Act. And then there's a chronic care program that's been in place for quite a while through the area agencies on aging, and they provide services in the home. It can also be an extender, care management extender for you and some of your patients, particularly those with social service challenges. And there are home health agencies that I mentioned earlier that are being trained up to do more care management and a lot of visits post-hospitalization to try to avoid readmission. But are these programs clinically and cost-effective? Are they, what we've talked about? The Intermountain Medical Group that I talked about earlier, or mentioned earlier, again, they took referrals from anyone that thought a patient needed services, and and this is the group they targeted, again, mostly frail elderly. And they felt that their results were that it improved clinical outcomes, increased physician efficiencies, increased physician and staff satisfaction, increased patient satisfaction about the care they are receiving there, and it spread the word for more patients to come there. It did decrease the emergency department visits and avoidable hospitalizations, and so this helped them preparing for quality-based reimbursement changes because they can demonstrate that. And some billing for nursing services can offset some of these costs. So yes, they felt, and they were looking at any patient, most complex down to even the most simple patient needing health coaching, they felt it could be very useful, very important for them, or it was important for them and successful for them. But again, are they cost effective? If patients are carefully selected based on utilization and ability to respond to care management, this could reduce costs, preparing for a different reimbursement scenario in the future. And this program does align with NCQA, patient-centered medical home certification criteria, and meaningful use standards. So that could be effective, a reason for its effectiveness, and there's probably other reasons too. I just want to throw this up there, showing that there is billing for RN care manager coordinator that has been developed. This is a chart out of the Peace Health Toolkit, and it gives the levels and what kind of care management is provided and the typical time that the care management manager spends with the patient and what kind of billing there is. The tool did not show the reimbursement for each level, but that could be easily determined. So where do we go from here? Well, use the patient-centered medical home model as your guide in practice transformation. Create a care management program looking through the lens of the PCMH. Perhaps looking at care management could be your starting place for the work you do in developing a patient-centered medical home. And the Department of Health can help. We are about to launch our next series of patient-centered medical home quality improvement initiatives for primary care early next quarter in March. And again, this is part of our Healthy Communities Washington at the Department of Health, and our program is called Washington Healthcare Improvement Network, or WIN. We will continue to support practices in transformation, and we just ended last September, or September a year ago, ended a 2-year patient-centered medical home collaborative. So we're going to continue to support practices in this transformation, and we'll retain the best parts of the original IHI breakthrough collaborative model, but we want to move faster and reach more in the coming years. We'll include peer-to-peer learning, practical examples, action plans, expert faculty, sharing of best practices, coaching. There'll be coaches. There's going to be a community or regional deep dive work, while there is a more self-paced state level or self-serve program going on. And we'll use, clinics will use an assessment process to tailor, to have services tailored to them by us. Some of our key partners are Quality Health, the Washington Association of Community Health and Migrant Centers, University of Washington Ames Center, Washington Chapter American Academy of Pediatrics, the Home Care Association of Washington. Some of these regional health alliances popping up or have been here for a while, and many more. Our goals are stable from the past. We want to improve the patient experience, improve the provider experience, improve clinical outcomes by increasing prevention care and improving chronic condition care. We want to reduce avoidable hospitalization and prevent ED visits and reduce rehospitalizations within 30 days, those 30-day readmissions, reduce costs, and improve overall quality. The three basic domains of our work are patient-centered health homes, the transitions improvement, working with Qualis Health, Home Care Association Washington, and the smooth transition project sponsored by Washington State Hospital Association, Washington State Medical Association, and Puget Sound Health Alliance, which bridge directly with primary care. So we're working with them on the transitions projects. And care management is the third major area, which are nurses and social workers embedded in primary care health home teams for patients with multiple chronic health conditions, and the coordination with care managers and coordinators in the community. This describes our statewide self-paced efforts that we'll be doing. This will be available to everyone that's interested. You do have to enroll and take an assessment, but then there'll be a whole catalog of resources that will be made available to you. We also will have our regional intensives that will start in Whatcom County in May, and Thurston Lewis Mason soon. And we'll be adding a new region every 6 to 12 months. And then this shows the transition work and the care management work as well. If you are interested in working with us or being included in webinars or care management work groups, listservs, or the like, please give me a call or email me, and I'll have my information at the end of this talk. So finally, part of the IOM report, the CHASM report that we're all familiar with from 2001, improving care for the chronically ill is one of the most important challenges facing our nation today. And so together we can figure out how to better do this, and we hope to help you all with this over the next couple of years with our WIN work. So thank you very much, and please don't hesitate to call myself, and I'm leading the care management efforts in these primary patient-centered medical home clinics. And Pat Justice, who's the manager of the Washington Patient-Centered Medical Home Improvement Project and Program, can be reached as well. So thank you very much. Goodbye.